to have We are very fortunate to have Dr. Mark Mesla, who attended Boston University for medical school, then came back to Chicago to complete his general surgery residency at Rush University Medical Center. He then spent time at Mayo Clinic, Florida for his fellowship in hepatobiliary and minimally invasive surgery. He has been on staff at Advocate Christ Medical Center since 2013 and has a practice that includes pancreatic cancer, biliary cancer, liver cancer, gastric cancer, adrenalectomy, and anti-reflux surgery. He is involved in the training of the general surgery residents from the University of Illinois in Chicago, and he is going to be speaking again in a virtual live presentation Friday, July 23rd at 3:30 p.m. through the Museum of Science and Industry. And I will put that information in the chat. So feel free to watch or share. It'll be tonight and July 23rd. Will both be great presentations. So now I introduce you to Dr. Mesla.
Thanks, Sue. Thanks to the Oakland Library for allowing us to have this session. Really appreciate being part of it. And thanks, Sue, for that kind introduction. So I'm going to try and go ahead and share my screen. Thanks for everyone that's joining in today. Really excited to get a chance to talk about something that's near and dear to my heart. Can you guys all see my screen, hopefully?
Yes.
All right, good. All right, so we're going to talk today about GERD, right? And so what is GERD? You may have heard it from your doctors, you may have Google searched it, but just GERD in its simple definition is gastroesophageal reflux disease, okay? And all it means is something simple. It just means when stomach acid is coming back up into the esophagus, right? And that happens normally. If you eat too much, eat a big meal, if you eat spicy food, if you eat a meal at 10 p.m. and then you lay down flat, you're going to have some reflux. Some of the gastric contents, I'm going to show you, hopefully you can see my laser pointer here, some contents from the stomach here coming up into the esophagus. So it's normal to have some reflux. When it becomes a disease, when it becomes GERD, is when there's severe symptoms that really can cause damage to the esophagus, or it affects your ability to live a normal life. So you're going to have to differentiate normal sort of reflux, incidental heartburn based on what you did, or gastroesophageal disease when it's so severe that it's either causing damage to your esophagus or affecting your life in a meaningful way. So if we take a zoom in here, this is a drawing that I just wanted to put up here to kind of what I talk to all my patients in the office about. There's basically two barriers your body has to prevent reflux from being severe. One of them is this muscle here called your diaphragm. And so we think about our diaphragm as what separates our chest from our abdomen, and it goes up and down every time you breathe. And that diaphragm has a tight little opening where the esophagus pops through to get from the chest to the abdomen. And that tight opening keeps the acid from coming back up into the chest. Because your body's made with sort of negative pressure in your chest. Take a deep breath. So naturally it wants to suck the stomach contents and the acid up into the chest. So you've got to have some barriers to prevent that from happening. The second, what we call barrier to reflux, is this one down here called the lower esophageal sphincter. And if anyone's been having problems with that heartburn and acid reflux and have been searching for it online, you probably hear people talk about this LES, or lower esophageal sphincter. Now, it's not an open and closed kind of aperture you think on a camera, for instance. It's more a muscle tightening. And there's a muscle here between the stomach and the esophagus that's naturally supposed to stay tightly closed. And it's supposed to open and relax when you eat, but then it's supposed to tightly close again after you eat to keep the stomach contents in the stomach. And in almost all patients with gastroesophageal reflux disease, that sphincter valve is not working. And so acid can come right back up the esophagus, because that valve just does not stay tightly closed. So what are the symptoms that people get with GERD, right? We like to separate them into basically two broad categories, the typical symptoms and then the atypical symptoms. So the typical symptoms are your classic heartburn, that burning sensation like fires coming up your chest. That's pretty classic. It can involve regurgitation or throwing up foods, because literally the things in your stomach have no barrier. They come all the way back up. Or something else called dysphagia. Now, dysphagia is a medical term for basically food getting stuck on the way down. So you eat food and you feel like, oh, it's just stuck right there. The chest can be quite uncomfortable, quite painful. Sometimes even people think they're having a heart attack. Even with heartburn, sometimes people think they're having a heart attack. The other category is atypical symptoms. That includes chest pain, chronic cough from acid coming back up and irritating your lungs, a hoarse voice from the same reason, acid coming back up, all the way up your esophagus and infecting your vocal cords, causing inflammation. People sometimes can have this water brash sensation. It's that feeling of foaming mucus in the back of their mouth, either when they wake up in the middle of the night or first thing in the morning if they're laying flat, especially. And sometimes people can have such breathing problems from the acid coming up in and going back down to their lungs that they can really get bad asthma exacerbation. And this is interesting because it doesn't usually respond to the normal inhalers that we would think treat asthma, because it's really irritation from the acid coming all the way back up. So we typically separate these symptoms into these two categories, typical and atypical, because the typical symptoms seem to respond more to our treatments. Atypical symptoms have a lot of other things that can cause those as well. So they often do respond, but they can be harder to tease out and really determine, is that from heartburn, from GERD? Now, what's important for us as physicians is to not just define the symptoms, but really say how severe they are for our patients and how often they happen, right? Because that's going to, as you're going to see in the next few slides, going to really affect how we manage our patients, how we treat them. And so it really is important to identify how severe it is, how often it is. And it's an important distinction for everyone to make, because if it's something that just is mild, like I said, you eat some spicy food, you eat something hot, you get some heartburn, and it happens once a month, probably not bad enough that you need to see it, to need to have some interventions on. But if you're getting severe heartburn, no matter what you're eating, and it's happening 3 times a day and you can't sleep flat at night, then that's when we're talking about, really having gastroesophageal reflux disease and needing something done. So when we look at those patients who are having mild symptoms and rare, intermittent is defined fewer than 2 times a week. Usually, if you see either your primary care doctor or a gastroenterologist, they're going to start with some of these sort of what we call lifestyle modifications. If you're overweight, losing weight may help, because it's just a pressure thing. If there's a lot of weight in your abdomen, that's just pushing up on the acid on the contents of the stomach coming back up. Laying flat, same thing. It's gravity. Laying flat's a problem, because when you're laying flat, all the stomach contents come easily up your esophagus. So if you stay upright for the first few hours after eating, or even elevating the head of your bed, not just putting your back up, but literally angling your entire bed, that'll let gravity keep the contents of your stomach in the stomach, make it harder for it to come up into your esophagus and cause the inflammation. And the other thing is eliminating trigger foods. I should just title this section, Eliminating Delicious Foods. These are things commonly people eat: caffeine, chocolate, spicy food, carbonated beverages. Those are all things that can cause more acid to come back up or irritate the esophagus. But when it comes to things like caffeine or peppermint, those things actually relax that lower esophageal sphincter, that muscle I was telling you before, that valve that's supposed to keep the stomach contents in the stomach. Those get relaxed with certain triggers, and that can make it more likely for acid to come back up. So if you have mild symptoms and you can do these modifications, great, that may be all you need. Now, sometimes that's not quite enough, and people turn to over-the-counter things, right? Like antacids, Tums, Mylanta. Those things don't really prevent the reflux. All they do is neutralize the acid, right? So if you remember from high school chemistry class, the opposite of acid is a base. All these medications are just bases. And so they just neutralize the acid contents in your stomach and they make you feel better, right? It causes immediate relief, but the problem is it's not long-lasting relief. So if you have really bad GERD, you may feel better, a few minutes after you take it, but that's not going to last if you're having really, really bad reflux. The next sort of level of medications that your doctor may put you on are H2 blockers or histamine 2 blockers. And these are one of the first classes of medications that actually try to stop the stomach from making acid by basically blocking the histamine, which makes the acid pumps go. And so these work quite well, but they don't work immediately. They can take 2 to 3 hours to work, and they only last 4 to 10 hours. So you usually have to take this a couple times a day. They're the older class of medications. They work, they don't work great, but some people have quite mild symptoms. Maybe that's all they need, just a little something to take them over the edge as an addition to the lifestyle modification. Now, those are all patients, everyone with mild symptoms, how we start with, right? But most of the patients are coming to see us especially me as a surgeon, have quite severe symptoms, right? So when we define severe symptoms, we're talking about more than 2 episodes a week and maybe severe esophagitis, which is just our medical term for inflammation of the esophagus. So when your esophagus not just irritated, but now it's actually inflamed because there's so much caustic action of the acid coming back up. And those next set of medications are typically be started on something called a proton pump inhibitor, right? So if you think about the stomach organ making acid to digest the foods you eat, it's these little proton pumps, these little glands in your stomach that are pumping out the acid. And so this class of medications actually turns those acid pumps off. It literally shuts them off. They're very effective. They need to be taken 30 minutes before the first meal of the day. That's when they're most effective. If you take it in the middle of the afternoon or take it at night, not quite as effective. Taking it 30 minutes before your first meal of the day. It's important to shut those pumps off before you start eating food. Now, those need to be taken daily because it's not the kind of thing like the neutralizing the acid, like a Tums, for instance. These are something that you take daily to keep those acid pumps off to prevent them coming back up. And most patients should get symptom relief within the first few days or at least the first week of starting the medication. And they're very, very effective. Sometimes we get patients coming to see us saying, I have severe heartburn and I've been on these PPIs and they never worked from the start. It's usually a worrisome sign for us that maybe something else is going on because these medications are so effective that if it's really acid reflux, if it's really heartburn, these will take care of symptoms. Now, they don't work forever. We're going to talk about that in a few minutes. And so sometimes people say, yep, they worked great. And after 6 months or a year, now they stop being as effective. That's normal. That can happen as your body gets used to it. But they are so effective that in cases with real heartburn, they should work. They should work pretty quickly. So a lot of those steps, the lifestyle modifications, the dietary modifications, the H2 blockers, these PPIs or proton pump inhibitors are often prescribed by primary care doctors. They see it. Gastrointestinal disease is so common that it's seen in tens of millions of citizens in the US every year that it's oftentimes taken care of, and maybe that's the end. Now, sometimes those aren't enough, and you may get sent to see a gastroenterologist. So that's a medical doctor who specializes in the GI tract, like the esophagus, the stomach, the colon, the small intestine. And what you're often sent to see a janitor for is for some type of procedure to really see how bad your GERD is. And the gastroenterologist may perform what's called an EGD or an endoscopy. And that's a procedure where you're under anesthesia, you're asleep, and they put a camera through the mouth, and you can see here on this drawing, it goes down the throat and it goes in the esophagus and all the way to the stomach. And so it can look at the stomach lining, look for ulcers, look for acid in the stomach. And then within the esophagus, it can look at the esophagus and look for signs of severe inflammation. And we typically do this when maybe it's an unclear diagnosis, is this heartburn or not? Or if the symptoms are so severe, we need to say, hey, how bad is this inflammation? How bad does that esophagus look? And one of the things that I can look for is that esophagitis, that term before, the inflammation of the esophagus. So these are some pictures of what the GI doctor would see on that scope. So remember that long tube, it's got a camera on the end, and they're literally looking at the picture. So if you look at this picture here on the top left, this grade N. So these are just a fancy term for how they grade esophagitis. But this little opening here, that's that lower esophageal sphincter, that valve. So if you imagine this camera is up in the esophagus and we're looking down into the stomach, but you can't see the stomach because that valve is closed like it should be. That's normal. Now, if you look at the next picture, you see that valve is wide open, right? So just like food goes down, now acid can come right back up. And you start to see some inflammation there. Now, as you go to the next set of photos, grade A, B, C, D, you see a lot of this different tissue here. See that red, angry looking tissue where there's more of it in that picture, even more of it here in this, what we call grade C esophagitis. And this is the esophagus is getting just burned by the acid. You know, your stomach is used to having acid in it. And there's actually barriers that your stomach has to prevent the acid in the stomach from ruining the stomach wall. But your esophagus doesn't have those barriers. It's not meant to see the acid. And so when it does see the acid, it really causes this injury and this esophagitis and inflammation of the esophagus. And that's really what you're feeling. That heartburn you're feeling is you're feeling your esophagus, the lining of your esophagus, burning and discomfort and inflamed. Sometimes the scope may not be enough, and we may do other tests, some x-ray tests to look for something called a hiatal hernia, which we'll talk about in a little bit. And they may even do another study called a pH probe. This sounds fancy and sounds like something out of Star Trek, but the GI doctor can put a tiny little chip in your esophagus and attach it to the wall of your esophagus. And you carry on this little monitor on your belt for 1 or 2 or 3 days. And that little chip is actually measuring how much acid your esophagus is seeing and sending that information to the little patch you carry around with you. And then your gastroenterologist can actually analyze and say, yep, your esophagus is seeing way abnormal amounts of acid. It's normal to see a little bit, but they could say you're seeing way more acid than you should be. This is really a problem. We need to do something about it. So if you've been researching and looking into information, you may have heard another term, something called Barrett's esophagitis. Okay, and Barrett's esophagitis is a dangerous thing. So when we think of inflammation in the esophagus, like I told you, that's uncomfortable, that's bad. Barrett's esophagitis is the next level when actually the irritation and the acid is causing such damage to the esophagus that it's actually changing the lining of the esophagus and changing fundamentally how the esophagus looks. And this is really dangerous because Barrett's esophagitis is precancerous if it's not treated, right? And so we think of that cascade, these are the fancy terms, but heartburn can lead to metaplasia, basically the changing the lining. And then that causes these precancerous conditions that could be low grade, not so worrisome, high grade, very worrisome, or full-blown adenocarcinoma or esophageal cancer. And this is a very clear cascade that if this heartburn or reflux GERD is not treated, many patients can go down this cascade. And if we catch it in the gastroesophageal disease stage or metaplasia or low-grade dysplasia or even high-grade dysplasia, things can be done to treat it without having a full-blown cancer. But if nothing's done, Barrett's esophagitis will absolutely turn into esophageal cancer, okay? And so there are really two factors in treating patients that we see with this Barrett's esophagitis. One is you've got to get rid of that abnormal tissue because that tissue is precancerous. Now, it doesn't always mean surgery, and usually these days it doesn't mean surgery. That can often be done by the GI doctor, by the gastroenterologist with that scope. They can use something called radiofrequency ablation, basically burning or killing those precancerous cells, or they can actually strip off those precancerous cells and remove them, right? So that's great. You want to get rid of that abnormal precancerous tissue, and that's a super important step. But the next step is also important, is that you've got to stop that heartburn. Because if you get rid of that abnormal tissue, but you don't stop the heartburn, it's just going to come right back, right? You don't fix the fundamental underlying problem. So in our patients who have Barrett's esophagitis, we really got to think about those two things. And it's usually a discussion between a surgeon like myself and a gastroenterologist. How are we going to treat them? You could do one or the other. One could go first, number two go first, or vice versa. But you need to have a coordinated team effort to tackle this, because just doing one without the other is really not sufficient. Okay. So we talked a little bit about mild symptoms, moderate symptoms, severe symptoms, how we manage them medically when you see a GI doctor. The next step I just want to touch on is, what do we do from a surgery standpoint? When is it so severe that you need to see a surgeon, and what do we do in surgery to help reflux? So why should you consider surgery, right? And so most of the time, the things I think about with my patients, it's really when you're really having symptoms that are occurring even while you're on strong medications. We call those breakthrough symptoms. So you're on the medications, but it's not enough, and you're still having the severe heartburn, the feeling of food getting stuck, the regurgitation. How about when your heartburn is negatively impacting your quality of life? Patients come to us all the time. I can't eat out because it hurts so much. I can't do the things I normally do. I can't go to work. So those are absolutely reasons that maybe we need to consider surgery. We worry about the potential risks and complications of GERD. So things I just talked to you about, that Barrett's esophagitis turning into esophageal cancer. Some patients feel great with the medications. I take the medications, my symptoms are gone. I just don't want to take a medication for the rest of my life. And this definitely happens in our patients, especially in our younger patients that have bad reflux. And they think, boy, am I going to be on this medication for my whole life? And they need to have something done so they can get off of those medications. And they may be just concerned about the side effects of those medications. And that came into the media probably about 2018 or 2019, they got a lot of media attention for this because some of those medications were found to be maybe associated with vascular disease and dementia and kidney dysfunction. It's just inconvenient to have to take a medicine every day if you can avoid it, as well as the cost of the medication. So we talked about the benefits of medications, right? They reduce the amount of acid in your stomach, they reduce the inflammation in your esophagus, they give you a lot of symptom relief, but they may not be permanent. Because the limit is those medications don't really get to the root cause of the reflux, and that's really that lower esophageal sphincter being wide open and not being tight. Doesn't really prevent reflux, they're just sort of turning off the acid or neutralizing the acid. But fluid is still in your stomach and that still comes up and causes problems, right? If you look at patients that are on acid medications, like the proton pump inhibitor, sort of the gold standard medicine for it, this study showed that 40% of patients still had breakthrough symptoms. So 60% felt better, but 40% still had severe symptoms. And when those patients had symptoms, even on medications, it often happened 2 to 4 times a week or 5 more times a week, which we define as high frequency, right? Greater than twice a week is considered severe. So when we look at it, the acid medications don't really prevent the reflux per se. They just prevent it from being so acidic, so you don't maybe sense it as much, right? And so there's this thought that maybe medications are good, but they sort of can mask the symptoms, and they don't really stop the GERD itself. So if you look at this sort of table chart here, you can see that patients who are off or not taking medications, they have a certain amount of reflux episodes, right? And this light gray color is the acid reflux, and the dark gray color is the non-acid reflux. When you put patients on those proton pump inhibitors, their acid reflux absolutely goes down because you turn off those acid pumps. But now their non-acid reflux goes up. So they're still having the same amount of reflux, it's just not as acidic, right? So it's good for short-term, temporary relief, but in the long term, it's not really getting to sort of the root problem of the reflux and why it's causing the damage. And this is what I was referencing earlier, all these sort of worrisome things that came out about long-term risks of PPIs. Now, some of them are true, a lot of them are sort of media hype, but the one interesting thing is that the FDA approval for proton pump inhibitors is really meant to be only about a 6 to 8 week duration. You're supposed to take it. If you get better, it's supposed to come off of the medication because it was never really studied in this long-term way. But I'll tell you, I have patients coming to see me all the time that have been on these proton pump inhibitors for 10, 15, 20 years, and maybe they want to get off it, or they read these reports and are kind of concerned and want to get off of it. So what can we do surgically, right? So we're going to talk about a couple of these. So one is what's called a fundoplication or a wrap, and the other is called links or a magnetic sphincter augmentation. I'll talk about what these are. So I just put on here 2 arcade songs, and I want to highlight the importance of this. Historically, surgeons, I'm talking 20, 30 years ago, maybe did a couple of these surgeries a year, here and there. Maybe they had good outcomes, maybe they had bad outcomes. And when they had bad outcomes, there would be pretty significant complications, and patients would be miserable and not feeling well. And so because of that sort of history, primary care doctors and gastroenterologists were sort of nervous to send patients to see a surgeon because they thought, well, it may help, it may not help. I don't really want them to be worse, right? This day and age, everything has become so specialized in medicine that physicians and surgeons are all really more specialized in certain fields and niches. And that allows you to sort of do more and keep up to date on all the latest technologies and techniques for it. And just to simply doing more, taking care of these patients more, you know how to select which patients benefit most, which patients won't benefit from surgery, who will have issues after surgery, how we can get through those issues. And so outcomes are much better, as many things in life in general, when you're seeing someone who takes care of that a lot versus when you're someone who does them occasionally. And so as Sue said in introduction, I joined Advocate Christ Medical Center in late 2013. So 2014 was my first year there, and I really have a passion, desire for gastroesophageal reflux disease and the treatment of it. And so that first year we treated 18 patients, and the next year 24 patients, and 33 patients, and 50 patients. And in the last couple of years, we've treated over 80 patients for this on an annual basis. You see the number and it's been a really important teamwork with our gastroenterology colleagues in deciding who would benefit most. How do we figure out which patients need surgery and which patients maybe just need to be medically controlled? And that teamwork has really led us to ideally, at least in my mind, feel like we've really helped a lot of patients getting control of their heartburn symptoms. So when you hear about surgery, right, you hear about the fundoplication, which is just, again, a medical term for the wrap, right, a wrap. We can wrap the stomach, and it's really just a way to make that lower esophageal sphincter tighter, right? This can be, you'll hear things like a complete wrap or a partial wrap, or it used to be done from the chest with a big incision through the ribs, and then it was done in an open fashion. So this was, we call this a Nissen fundoplication after the surgeon in the 1950s, Dr. Rudolf Nissen, actually described it in the 1950s. And that was a big open operation, a big incision in the hospital for many, many days, healing up from it, dealing with the pain. And it worked, but it was never really took off because it was such an invasive operation. And then, you know, around the late 90s, we started doing a lot more surgeries laparoscopically. And so laparoscopically means these small little incisions. And you can see here, we use these little trocars where we basically fill the abdomen up with carbon dioxide gas, and it gives us a lot of room. And then we use long instruments through these trocars, or these little valves we put in. And we have cameras and instruments, and so we do all the surgery with these little incisions and not have to make a big incision to do all the work. These days, it's typically a 1 to 2 hour procedure. You stay overnight in the hospital, typically go home the next day. There's some modifications to your diet. I typically tell patients they're going to stay on liquids for 1 week after surgery, and then soft foods for the next 3 weeks, and just to let everything heal up. We don't want food getting stuck while that wrap is healing and everything's healing. Usually about a week or 2 off of work, but they're just healing from the incisions and everything, right? And so what a fundoplication is literally taking that upper part of the stomach and wrapping it around the esophagus. So the description I like to use that I learned in my fellowship training was like a shirt collar going around the neck. You take the collar of the stomach and you wrap it around the esophagus, and that makes that valve tighter to prevent the acid from going back up. Now, it's very good at preventing the acid from going back up. In the olden days, people used to make it so tight that you couldn't even burp out the gas in your stomach back out. And so most patients with bad reflux think that sounds great. My problem is my reflux, I'm burping all the time and it's loud and it's belching. If I'd not burp, that'd be fantastic. But it's actually normal for your body to be able to burp, and it's a good pressure release valve. If you drink a lot of pop and your stomach fills with all that carbonation, you're quite uncomfortable until you can burp it back out. And so the only days when they made the wraps too tight, people couldn't burp out, and that was a problem. So this day, we're very careful in the specific way we make it to not make the wrap too tight. But sometimes it could be so tight that it could be hard to throw up if you need to throw up. And sometimes people get this kind of bloating after this surgery because the stomach sort of anatomy is a bit changed. And here's just another drawing of sort of what we do. So this is the floppy part of the stomach up here, and it's literally brought all the way behind the esophagus. And then we can wrap it fully around, or sometimes we have to wrap it part of the way around, about 3/4 of the way around the esophagus. Now, I didn't touch on this. I realize now I didn't really have a slide to this, but you remember when we talked about that other barrier to reflux is the diaphragm. So you're seeing in this drawing right here, the diaphragm is that muscle going up and down every time you breathe. So some of you in the audience may have heard of or been diagnosed, or family was diagnosed with something called a hiatal hernia. And what that is that's when that diaphragm, that little opening in the diaphragm, which should be a little opening in the diaphragm the esophagus pops through, is too wide. And their stomach gets pushed up into the chest or sucked up into the chest. And that makes that valve weaker, makes heartburn even weaker, makes it even easier for the food contents and stomach acid to go up into the esophagus. So anytime we're operating on anyone for heartburn, we have to make sure if there is a hiatal hernia, we need to fix that. And then what we fix that is by putting in stitches to tighten up that diaphragm tighter around the esophagus so it's not such a wide opening, right? So that's an integral part of the operation as well. So the sort of the new kid on the block, if you will, it's been almost 10 years out now, is something called LINX. And this was FDA approved in 2012. It's quite safe, quite effective, and it's also a minimally invasive or laparoscopic way of fixing heartburn. And what you can see here is what the device is. It literally looks like this. This is way blown up. The actual device is about the size of a quarter, a silver dollar. And these are little titanium-coated beads that, titanium-coated magnets that are on this bracelet. And the way I think about it, the way I tell my patients about it, it's like those kind of candy bars you have when we were a kid, but instead of candy, it's magnets covered in titanium around it, and it's flexible. It opens and closes. And the way it's supposed to work is that when you're swallowing and eating food, the food pushing down your esophagus opens that device up, and the food goes into your stomach like it normally should. But then after the food goes through, the magnets pull it back closed, and that closed position basically makes that lower esophageal sphincter, that valve between your esophagus and stomach, stronger, so the acid doesn't come back up. So it's done laparoscopically. And you can see here in this drawing, here's the device sitting right around the esophagus, nice and closed, keeping the acid coming back up. And as you swallow food, food pushes down, it opens it up, and then the food can go into the stomach. It's supposed to be a video, but I don't think it works, unfortunately. So this is also a laparoscopic procedure with the same small incisions. Typically, just a little bit faster because we're not moving anything. We're not moving the stomach or wrapping anything or stitching anything. So typically, it's less than 1 hour. Usually, patients go home the same day. A key difference is because we're not changing any stomach anatomy, we're not doing anything, you can actually eat regular food right away. And you're able to really belch and vomit if you needed to, if you ate something bad or had some bad viral illness. And we think they typically have less side effects because we're not changing that anatomy of the stomach. And just like if you put in laparoscopically, this can be also removed laparoscopically, again, without changing any anatomy. So this sounded great. When the company came out with it, people said, oh, wow, this is interesting. And a lot of people said, I'm a little bit nervous about that. And so we as physicians like to see data and see the numbers. And so the first big paper that came out was a 1-year study. So it's great, you can put this in patients, but how are they feeling a year later, right? And this was very, very encouraging. They saw 80% of patients were completely off of their acid medications a year after surgery. And 98% of patients had no bothersome heartburn symptoms affecting their sleep. 98% of patients had no need to change anything in their diet. They could eat whatever they wanted. And 94% of patients were satisfied with their overall condition after having LINX. So great, that sounds good. That's 1 year. But again, most of us are quite skeptical. Most patients are quite skeptical as well. They said, okay, 1 year is great, but I'm planning to live a lot longer than 1 year. So that doesn't really convince me yet. And so more and more data came out. And so there was a study that came out in 2015 of 5-year data. And it was really impressive that it showed that 5 years out, patients were doing basically just as well they were doing 1 year out. So still 88% of patients are completely off of their antacid medications. 94% of patients had an improved quality of life based on a score for their heartburn. 85% of patients, if you actually tested all those patients, put that little chip like we talked about earlier that sends the information to that little purse you wear around for a day or two, they actually measured, 80% of patients had less acid coming back up by their esophagus, and 91% of patients were satisfied with their oral condition 5 years after their LINX. So that was more encouraging data. And that was sort of the tipping point that people started doing more and more of this, or at least surgeons who do a lot of anti-reflux surgery said, hey, this is something important. We should be able to offer this to patients that, especially patients that seem like this would make sense for them, right? And so just in summary, I went through a lot of information today. Just in summary, the key points I want to make is that really GERD or gastroesophageal reflux disease is a chronic digestive disease caused really by that weak lower esophageal sphincter. It's really much more than just heartburn alone. It can cause quite significant serious complications like esophagitis, strictures. When your esophagus is scarred in, it basically narrows down. Barrett's esophagus, which we talked about, which can lead to esophageal cancer. And medications are very good at providing symptom relief, but they don't really get to the underlying cause of GERD. They don't really prevent reflux. And so if your symptoms are so severe, or you're having these damaging changes to your esophagus, then you really need to consider some surgery to really treat the underlying cause, right? Because we talked about it's an abnormal disorder of that sphincter and that valve. And the way we fix the valve is either with that fundoplication, wrapping the stomach around the valve, or LINX to really make that stronger. So that's what I had for tonight. I know I tend to talk fast, so I apologize if that was too fast. But I'd love to see if you guys have any questions, want to go over anything. I'm happy to talk some more, maybe more in depth about any of the topics that I maybe sort of went over quickly.
Hi, DeAndre.
Hello, doctor. Oh, sorry.
Oh, no, I'm sorry. You can go ahead. Heartburn esophagus. And I didn't have
Ooh, unfortunately, I can't quite hear your question. Someone's happy with the connection.
Yeah.
hernia.
I can't. Oh, there's something wrong with the connection. I'm sorry. I can't quite hear that.
Is there any way you could try and type it?
And so I have to go see him. I think about maybe some years ago. Wait, I'm sorry. What? Sure. Oh, sure I can. You know what? I don't think we have a okay.
Maybe while you're typing it, there's someone else I think who had a question in the audience.
Hi, my name is DeAndre Hawley. I'm an intern for Susan Latocha.
Oh, great.
My question was if there are any holistic ways that individuals could take in case they don't want to take the medication or they're just opting out of taking the medication.
Yeah. So I have to confess, I don't know them specifically by name, but they're absolutely medications that work, and they seem to work in the same kind of things. They're either something that's going to neutralize the acid. So some people come in with different sort of bases they find in different, household liquids and things like that to try to neutralize the acid, or other medications that maybe have been found to sort of decrease acid production. So there are things, I think if they're mild symptoms and they're safe, I think that's, a fair way to start. But our worry is when patients get really severe symptoms and have those severe signs of inflammation, that often may not be enough.
So the other question that was asked, there's a couple, but the first one, will the doctor recommend what surgery is best for the patient, or can the patient choose which surgery they prefer?
That is a great question. So I think it's very important that a surgeon doesn't specialize in typically one surgery. Really, we should specialize in a disease, right? And so I think about specializing in reflux disease and understand the different surgical options. So there are various tests that our patients go through to see maybe which type of operations would be best or they may or may not qualify for. And then, if their tests show that actually they're a candidate for multiple options, I really spend time to sit down and talk through what the options are, what the risks and benefits are. And it's really a discussion to myself and the patient, what makes the most sense, what they like, what they don't like. And I honestly tell you, I see the full gamut. I see patients say, I'm worried about the newest technology. I want what's the tried and true and the standard that's been, I feel more comfortable with that. That makes a lot of sense. And I have other patients that say, why do I want to do something that's been done for 40 or 50 years? I want the newest technology. I want the newest thing. And they sort of interested in that. And so it is absolutely up to the patient. I have never interested in talking someone into a certain surgery. More importantly, just saying, what are the different options, what you may or may not qualify for, and what are the risks and benefits of each. But for me as a surgeon, it makes no difference. My patients have to live with the outcomes for the rest of their lives. So I want to really make sure that it makes the most sense for them, they're comfortable with it, and that really it's going to help them in the long term.
A follow-up to that question. I have Barrett's esophago. I had the ablation. I also have a hernia. I have occasional breakthrough reflux. What next? I need to see a certain doctor in a few months as a follow-up. What next steps do you recommend? I'm not sure how much you can answer on that, but
yeah, no, it's actually a quite common story. I think if you've got reflux severe enough to have Barrett's, you really should be also sent to see a surgeon to talk about what can we do to prevent the acid from coming back and causing more and more Barrett's. So it's usually what often can happen is maybe the GI doctor did an ablation and they want to repeat a scope in a few months, make sure it didn't come back or get worse. And if that looks good, then they may say, okay, now it's time to have anti-reflux surgery to really prevent this thing in the long term. And so I think don't be afraid of the patient to speak up and say, I've done my research and I realize that maybe the medications aren't enough. If I still had Barrett's, especially if you're on medications and developed Barrett's on the medications, that's a worrisome sign. And then I think the next step, if it was bad enough that you had Barrett's, is to really talk about what can we do to get to the cause of the reflux. And if you have a hiatal hernia, that by definition, the medicines are never going to control that, because that's just a weakness in that diaphragm, and that really has to be corrected surgically in order to prevent reflux.
There was one more question in the chat here. Are there foods you can avoid to decrease the incidence of GERD?
Yeah, so those are those things we talked about earlier, the delicious foods, right? So caffeine, alcohol, chocolate, acidic things like tomatoes, pasta sauce, orange juice. Those are simple acids that can make more heartburn come back up. And then the peppermint's the other one that really relaxes that lower esophageal sphincter and makes the acid incontents come back up. So those are the typical things we recommend patients avoiding. But again, those are just broad generalizations. What is often helpful is patients to really, now to think about it, almost keep a little food diary and say, what are my trigger foods? What triggers me? So I really love it when our patients come in and say, I've noticed that when I do this, this, and this, my heartburn's terrible. When I avoid those things, my heartburn's fine. That really shows me that you're taking your health seriously and that you're noticing and sort of paying attention to what causes it. So there can be things that are different in you that aren't, the same for everyone else. But those are sort of the classic things that we think about. The acidic foods and the things that relax that lower esophageal sphincter are the ones that really tend to trigger heartburn.
Someone said, thank you to your previous answer. And then all my favorites was the comment on the.
Yeah, exactly. Right. That is unfortunately that is the case sometimes.
And I have no more questions in the chat here. Were there any more questions from the audience right now? No one? Okay.
Thank you. Thanks everyone for paying attention and being here tonight. Appreciate it.
Thank you so much. Thank you to you, Dr. Mesla. Oh, and there's one more that somebody, thank you again. And thank you to Sue Latosha and Dr. Mesla for putting this together. Sue has also listed about the speaking virtually through the Museum of Science and Industry, a live stream on Friday, July 23rd at 3:30 p.m. with a link there if you can join or pass it along.
Thank you very much, Megan. Thank you very much, Dr. Mesla. And thank you very much, everybody, for visiting and learning more about heartburn and GERD.
Have a good night, everyone. Take care.
Bye, everybody. Thank you.
Thank you.